All right, here we go on chapter 23, which I started on the last one, but realized they weren't my slides towards the end, so hopefully you didn't watch that one. So here we go. Here's my slides. So we're going to start all over. Cognition. Cognition represents a fundamental human feature that distinguishes living from existing. Okay, over here if you see as our little thing that the wheels of thinking are in progress. Cognition, the awareness brought about by the process of thinking, the act and process of knowing. So there's a lot of different things that can affect our cognition. It's primarily an intellectual and perceptual process, closely integrated with one's emotional and spiritual values. Profound disturbances in cognitive processing cloud or destroy the meaning of life's journey. And caring for people with profound cognition disturbances requires compassionate, empathetic, and understanding individuals. So a lot like we talked about today in class, that empathy, we're seeing that again, compassion, and being understanding people. Again, maybe we don't relate and we don't know what they're going through, but we can understand that it's difficult for them. So the clinical picture of delirium is an alteration in the level of consciousness, manifest as an altered awareness and inability to direct, focus, sustain, or shift attention, disorganized thinking, disorientation often to time and place, anxiety, restlessness, poor memory, delusional thinking. Delirium is the most common complication of hospitalization in the older adult. Many times delirium is caused by medication, or we've interrupted their sleep-wake schedule. Some of you may have heard of ICU psychosis. Patients get delirium from that because in the ICU, we never let them know when it's day or night because they're always sick. And if you see at the bottom, delirium is a medical emergency, and the way to fix it is to fix the underlying cause of it. So the clinical picture continued. Delirium is an acute cognitive disturbance and often reversible condition that is common in hospitalized patients, especially the elderly. Delirium is always due to an underlying physiological cause. So you have your predisposition there. You can read through those factors, and then we have other factors as well. You can see that it can be from toxicity from medications, can be from substance abuse, withdrawal, impaired respiratory function, and obviously not getting enough oxygen. And early recognition is key in reversal. However, one of the most poorly recognized conditions by nurses and docs, and at the bottom that actually says why. I can see part of it's cut off for you. So why do we think that is? Well, because when we have patients in hospital beds, especially if they're in upper age, we'll start contributing it to, well, they haven't been sleeping well, or, they're sick, so they're confused, and then often it's too late by the time we realize that it's actually delirium. The overall assessment, we have 4 cardinal features of delirium. We have the acute onset and fluctuating course, the reduced ability to direct, focus, shift, and sustain attention, disorganized thinking, and disturbance of consciousness. The failure to quickly detect and to treat delirium is associated with a significant increase in morbidity and mortality, so we may not be able to reverse it, and patients can actually die. So we want to be very, very careful and always recognizing if our patient is having some kind of delirium. So we have cognitive and perceptual disturbances, so illusions. We have errors in our sensory stimuli. So if you look over here, you look at this, is it a rabbit or a duck? If you look at it towards the left with a beak, now it's a duck. If you look at it as a face of a rabbit over here with ears, it's then a rabbit. So illusions often are things that there's something there, but we see it differently. So if a patient is looking at a coat hanging on a coat hanger or a rack, they may actually see somebody looking at them, but in reality it's a coat. So that's your illusion. Hallucinations is a false sensory stimuli. Visual are common in delirium. Tactile may also accompany. Tactile is like the picture of the hand over here, where the patient feels the bugs crawling on them. Auditory is not as common in delirium, but most common in schizophrenia. So when we get to schizophrenia, you'll find that it's much more common for a patient with schizophrenia to have auditory hallucinations and not as common to have visual. But with delirium, we'll see more visual than we will auditory. So we need to make sure we're taking care of the patient's physical needs. They can have self-care deficit, changes in sleep-wake cycle, and medications are always a suspect of delirium. So we need to see what are the new meds, what have we changed, moods and physical behaviors, and our self-assessment. And then you'll see, check yourself. Remember, this person before delirium was just like you. So even though delirium is very hard to take care of, a person that's going through it, we have to be careful and remember that we've caused this, or something has caused this. This is not who they were before. Assessment guidelines establish what the person's normal level of consciousness was, and who can we get this info from? Typically the patient's families. You will, I promise you, work with families that will tell you that their mom never has acted this way before, or their husband has never acted this way before. This is not normal what we're seeing. We want to assess for potential injury from wandering or for falls, and remain non-judgmental and talk with other staff members about concerns. You have diagnoses and outcomes that are identified on table 23.3. Whoops, I skipped too fast. Your implementation, we want to prevent physical harm due to confusion, aggression, or fluid and electrolyte imbalances. We perform comprehensive assessments, assist with proper health management, and we want to get rid of the underlying cause and use supportive measures to relieve distress. Our evaluation, the patient will remain safe, the patient will be ANO ×3, and the underlying cause will be treated and improved. So moving on to dementia. Dementia is progressive deterioration of cognitive functioning and global impairment of intellect. There is no change in consciousness with dementia. Difficulty with memory, problem solving, and complex attention. And severe memory loss is not a normal part of aging. However, slight forgetfulness is a common phenomenon of the aging process. So dementia is not a normal part of aging. It's not going to be that every older person gets dementia. You have mild and major neurocognitive disorders, and all this list underneath can be due to any one of these things. Different things you see. You have your Alzheimer's, your traumatic brain injuries, substances, and substance withdrawal, and then different medical conditions. Application of the nursing process. So we're looking at the general assessment, and then we're going to cover some more of these things in just a second. Alzheimer's disease, most common type of dementia. It accounts for 60 to 80% of all dementias. Very devastating for the person and their families. 5.4 million Americans have Alzheimer's disease, and it's progressive illness that strikes indiscriminately. So there is no one person it's going to pick on versus others. Here we go. Stages of Alzheimer's disease. So if you look on the right, you've got your early, your middle, and your late stages. Confabulation is one of your words, your key terms. That's in the early stage. This is the creations of stories or answers in place of actual memories to maintain self-esteem. So if you're talking with somebody that has the early stage of Alzheimer's disease, they may go ahead and add to stories or kind of make up other memories because they're trying to maintain something that they have forgotten. So you want to make sure that, you don't take this as them lying. This is a coping mechanism. Preservation, the repetition of phrases or behaviors, doing things over and over again. You'll see that with patients with early Alzheimer's. Memory impairment starts with the short term and progresses to the long term. Disturbances in executive functioning, so planning, organizing, abstract thinking, all these things you'll see disturbances in. In the middle stage of Alzheimer's disease, you're going to see aphasia. This is the loss of language ability. Starts with only having trouble with finding the correct word, progresses to only having a few words, and then by the late stages or in the end, the patient will be just babbling or be mute. Apraxia is the loss of purposeful movement. The patient will be unable to perform one's familiar and purposeful task, like dressing themselves. And agnosia is the loss of sensory ability or to be able to recognize objects. They cannot recognize familiar objects and sounds that they once could. Agraphia, this is the inability to read or write. This is going to be found in the late stage. Hyperorality, this is the need to taste, chew, and put everything into one's mouth. And hypermetamorphosis, this is manifested by touching everything in sight. So as you can see, unfortunately with Alzheimer's, you see a regression almost back to child, toddler, and then infant stages. Very, very sad disease and very hard to watch. So our own self-assessment, us as nurses, working with Alzheimer's disease patients can be stressful and frustrating. Both caregivers and family members alike experience the stress. Education is important. Having a realistic understanding about the disease is really good for ourselves, so we don't expect more than what the patient can perform. Establishing realistic outcomes and goals for our patient, and maintaining good self-care for you. And you always want to talk with a supervisor or another trusted coworker when experiencing stress in a workplace environment. So I don't think that I will be able to cover the last chapter in here, although I do know the last chapter will be relatively short. I'm going to actually go to bed, though, and record that for you guys tomorrow. And I will plan on seeing you all on Monday. If you have any questions or anything you need answered from any of this information that you've been given, please send me an email. I will also open up a forum in the discussion board for just questions about anything that we've covered. All right, have a good night.